So, Dr. Manley, are there any promising approaches or interventions aimed at reducing biomarker disparities that you've currently been exploring or are advocating for?
I would take several angles on this. One thing is there has to be much more community engagement and involvement, and really going to community groups, whether they're faith-based, whether they're barbershops, really going out where people are and letting them know about lung cancer disparities, biomarker testing, what you can do. The other way is also going to conferences where there are more diverse scholars that are attending. So a lot of these are STEM meetings. They may not be specific in lung cancer, but if you can go out there and get the word out about lung cancer and the disparities, then they can go back to their families and talk about screening and testing and making sure that their family members are aware. And then, we just published a paper recently that showed, the upstream part of biomarker testing is where are we starting at with our cell lines. We just did a review of all the lung cancer cell lines. Of over 800 cell lines, majority were European based. Only 31 cell lines in total were from Black African American populations. None were from Hispanic, none were from Native American and Pacific Islander, none from Alaskan Native. So just think about this. If that is our starting material for all of our biomarker testing and TCGA and databases, then everything we're developing is on a population that already has great access and outcomes, but they don't have the greatest disparities. So then you're getting through doing all these trials, and then you have biomarkers and you have immunotherapies coming out, and then you're seeing adverse events in these diverse populations at the end because you don't have the starting material.
And Dr. Sabari, after hearing Dr. Manley's comments about that, how do you or do you know of any approaches or interventions that are aimed at reducing these biomarker disparities? Because maybe they aren't being acknowledged yet. Maybe they're only being seen in certain populations.
Yeah, I think Dr. Manley hit it on the head. First off, we don't even know the correct or true numbers for certain mutations in specific patient populations. And I just read an article about, patients from Latin America, different rates of EGFR, ALK, and other mutations. You can imagine a study population from Africa, for example, and then, obviously studying a population, Black Americans here in the United States as well. We know that, most of the cell lines, most of the data that we've had, particularly TCGA, is from a Caucasian or North European patient population. So I think we need to do better in that sense. I think equally as important, our clinical trial enrollment needs to diversify. Again, it's mostly women, it's mostly Caucasian women. We have very, very low rates of Hispanic patients enrolled on clinical trials, Blacks enrolled on clinical trials. So I think we need to do better in that sense. One thing that we've really pushed for in academic medicine is to at least report who is being enrolled on trials so that we can understand, is this data generalizable to my own clinical practice? And oftentimes, if you look at the clinical characteristics of patients enrolled on the trial, it likely does not match what you see in your own practices. So we need to do better in that sense. So I think the FDA and especially pharmaceutical companies are clearly looking to expand and broaden their inclusion criteria and also access to patients so that we can actually have a more diverse patient population that represents our country enrolled on these trials.